Welcome back to Navigating Cancer. I'm Dr. Joey Bennett. Wendy Hall with us again today, and our special guest tonight, Dr. Farhad Golkar, a surgeon at Inverness Surgical Associates. We were just talking about esophageal cancer, and I wanted to spend a little bit more time with this because one of the things you were mentioning is the difference between treating an early stage cancer versus a late stage cancer. And I've always had the opinion that if you look at cancers of anywhere in the intestinal tract, if they're early cancers, the first step is to surgically go and remove them and then decide whether or not chemotherapy or radiation may be indicated afterwards. But unfortunately, a lot of times we find more advanced cancers. And in a setting where we have a more advanced cancer, talk about kind of what your ideas are as far as the esophageal cancers go.
Sure. So I exactly agree with what you said about cancers of the GI tract. And basically, with cancers of the esophagus and actually the rectum as well, they're treated almost exactly the same. For advanced stages, it is absolutely recommended that patients undergo chemotherapy and radiation therapy first, then undergo surgery. It's shown to improve their outcome and improve their cancer-free survival time.
I mean, one of the other things we want to talk about, and I know everybody watching tonight has known someone in their family or a friend who has died of cancer, and a lot of times when I talk to patients and get their family history, they'll say, my grandfather died of liver cancer, and I'll go, really? Because liver cancer is not very common. What is more common is other cancers metastasizing or spreading to the liver. And historically, we're getting into another area surgically here that is very difficult and takes someone who has the training like Dr. Golkar has to deal with these tumors when they present to the liver, because without surgical resection, we're not going to cure these patients. Radiation therapy and chemotherapy by itself cannot cure a cancer that is metastasized, and we hopefully catch people early enough to where they have early disease. You and I have a patient in common right now that we've been working on who has been found to have an early lesion. Talk to me a little bit about liver cancer, both from the standpoint of primary cancer and of those that spread to the liver.
Sure. So as Dr. Bennett said, liver cancer itself is pretty rare. And so to play with the semantics, liver cancer is hepatocellular carcinoma. And as you see on the slide, that only, for the most part, happens in patients who have cirrhosis. And from whatever cause, hepatitis, alcohol, and that's not what we're going to focus on here, because it is, as Dr. Bennett says, pretty rare. Another type of liver cancer is a cholangiocarcinoma, which is even more rare. But the most common type of tumor to the liver is a metastasis from some other type of cancer, most commonly colorectal, but essentially any GI tract cancer can metastasize to the liver. And if we look at the next slide.
And I mean, and other cancers can as well. I mean, you can have lung cancer that metastasizes, breast cancer, melanomas. I think for the most part, what I have seen, though, is typically the only time we have a chance of curing someone with the cancer that has spread to the liver tends to come from the colon and the rectum, you know, that area.
That's exactly right. So once cancer has spread to an organ outside of that it started in, then you have stage 4 cancer. And patients who have stage 4 cancer usually are not candidates for any surgery, except, as Dr. Bennett said, for colorectal cancer. We have very good data that shows that we can even offer a cure in someone who has a stage 4 colorectal cancer with a metastasis to the liver.
Talk about some of the signs. I mean, the patient that you and I are dealing with, the sign is that I had done a PET scan for following the patient up, and we found it. He was totally asymptomatic. But in other patients, there are some signs that it can go to the liver.
Right. The signs, however, though, are pretty generic. Many patients, as you mentioned, are asymptomatic, or they have vague symptoms like abdominal pain or weight loss. And then very commonly, like you said, it's because of a patient who has had a cancer, who is now undergoing routine CT scans or having blood tests checked like a CEA level, and these start rising, and the doctor becomes worried about a recurrence of the cancer or a metastasis of the cancer, and that's how it's found. And
I mean, historically, this again is another medical situation that we have had to send out of the county. I mean, these patients have had to go out of the county, and when you know how hard that is when you're traveling and spending time down there, your family can't be with you, and so it's a tremendous asset to have the talent that Dr. Golkar brings to us to do these surgeries right here in the community for the same reasons we were talking about. If you wake up in the middle of the night with a complication, it's a long drive to Tampa, it's a long drive to Gainesville, it's a short drive to Citrus Memorial Hospital, and there is the surgeon who took care of you in the first place there to help if there are any complications, which we don't expect any, of course, but we always know that, you know, complications can occur. Go to the next slide for us, Bill. Talk about some of the tests. I think we already covered a little bit of this, though, that you can deal with when looking at this. You can find these abnormalities on ultrasounds, PET, CT scans, like I said. The other thing that sometimes is just laboratory tests can be out of whack, and all of a sudden that simple blood test sends you down a path of looking. If you find one of these things, do you biopsy it first, or do you just go in and do the surgery?
No, for a liver lesion that's a metastatic liver lesion, you should absolutely have a biopsy confirmation,
Okay.
Which is different than some other types of cancers. But in this situation, I would always obtain a biopsy.
And so now we found the cancer. The next picture is not necessarily a pretty one to look at. Describe what we're seeing here.
Yes, so the top picture is that of a liver that has multiple metastases to it. This is not a patient that would be an operative candidate. I'm just putting it up there so that you can see what grossly it looks like in the operating room. The metastases are usually whitish in color, and the liver is a dark red burgundy in color. The bottom picture there, briefly, is the liver divided into the segments that it comes in. There are 8 segments, as you see there, and those are the lines or the segments that I use when I plan operative intervention, meaning to remove parts of the liver.
And I think that gives you a very good idea about what's going on, because if you've got cancer just involving one segment or 2 segments or so, you can certainly go in and remove those, whereas if you have a picture like this where these white nodules are all throughout the liver, there's no segment left behind, and you can't live without a liver, and you're not going to get a transplant when you have cancer. So
that's right.
Go ahead and go to the next slide. Talk about how we've changed this.
Sure. As we mentioned earlier, metastatic lesions to the liver for colorectal cancer is curable, and so we have changed the way we view how we treat this, and essentially we are very aggressive in removing as many tumors as possible. And in the next slide, you'll see here, back in the day, we would only consider a patient who had maybe 1 metastasis. Now, essentially, you can see on the slide here where the dark line is patients who had over 4 liver metastases, and the other line is 1 to 3, and essentially their survival is the same. So the key here, and I'll show you on the next slide as well, again, if their metastases are on the right side of the liver or on the left side of the liver, again, it doesn't matter. You should be very, very aggressive with the amount of surgery you have. And this has been shown by data on the last slide here, that since 1928 to 2008, the survival for colorectal cancer has dramatically improved, and the way it's improved is by being aggressive, as I mentioned, and by having multidisciplinary management, meaning between a surgeon, between an oncologist, and everyone else involved with the care of these patients.
And I think it's very nice to see that it's not necessarily just the number of lesions, it's where they're located, so that we don't rule anyone out. Great program. I mean, very nice talking about esophageal, pancreatic, liver resections. Thank you very much for being with us tonight. We'll see you next week on Navigating Cancer.
Thank you.